I'm Surbhi Sidana. I'm an associate professor at Stanford University and a myeloma specialist. The study we are talking about today discusses real-world outcomes with Cilta-Cel or ciltacabtagene autoleucel CAR T-cell therapy in the real world for patients with relapsed refractory multiple myeloma. Now, this is a multi-center study from the U.S. Immunotherapy Myeloma Consortium. So 16 sites contributed data to this study, and I'd like to acknowledge my co-authors, especially my lead co-authors, who really, this was a tremendous team effort. So Cilta-Cel was the second BCMA-directed autologous CAR T that was FDA approved in the United States in 2022. And it was approved based on the CARTITUDE-1 trial, which was a 97-patient study that showed that in patients who are heavily pretreated with a median of 6 prior lines of therapy, the response rates were 98%, CR rates of over 80%, and a median progression-free survival nearing 3 years. We had never seen that in this patient population, and so we were all very excited. But the big question with the CAR T trials always is this going to translate into the real world? Because patients enrolling on CAR T trials have to meet very stringent eligibility criteria. They have to be progressing, but not progressing enough so that they can wait for a slot. They have to meet very other strict criteria. And so this is always a question. How will our patients in clinic who have a lot more comorbidities, who might be progressing more quickly, respond to this kind of therapy in terms of both safety and efficacy of CAR T? And so what we found was we had 255 patients who started with the process of apheresis or collecting their white cells to manufacture CAR T. Out of them, almost 93% were able to get CAR T infusion. 19 patients did not get a CAR T infusion, primarily due to disease progression or death in the interim. Initial manufacturing failure rate was a little bit higher, but the overall manufacturing failure rate was only 1%. So we have 236 patients who ultimately got CAR T. Now, some of them, 19%, got an out-of-spec product that did not meet the FDA criteria for whatever reason, either due to dose or viability for a commercial release product. And they were treated on an expanded access protocol. And I'd like to differentiate these two categories of patients. So I'll talk about two categories of patients, all 236 patients. And then for efficacy outcome, talk about patients who got a conforming product, that is 192 patients. So when you look at the overall outcomes, safety was very comparable to what we saw in the pivotal trial, despite more than half of the patients not meeting eligibility criteria for CARTITUDE-1, primarily because of comorbidities or cytopenias or performance status or prior BCMA-directed therapy. 14% of our patients who were infused got prior BCMA-directed therapy. And yet, grade 3 or 4 or higher CRS were seen in less than 5% of patients. ICANS rates were similar as well. Delayed neurotoxicity was seen in 10% of patients, with Parkinsonism seen in about 2% of patients. And this is a side effect that we are attuned to with Cilta-Cel more commonly than with other CAR Ts. The most common delayed neurotoxicity was cranial nerve palsies. Now, non-relapse mortality was 10%, which is numerically higher than that seen in the clinical trial. And this is something we really need to work on improving. And the most common cause of death was infection relating, stating that patients may need more aggressive prophylaxis and can we identify a particular subgroup of patients who are at a higher risk of infections. When we look at efficacy, the overall response rate in the entire 236 patient cohort was 89% and CR rate was 70%. When we look at the subcohort of patients with conforming CAR T product, the overall response rate was 94% and the CR rate was 74%. And most of the complete responses were MRD negative for patients who had evaluable MRD. Again, speaking to the fact that even though the patients did not meet the perfect trial conditions and had more comorbidities, they can derive significant benefit from this CAR T. Now, the median follow-up in our study was about 13 months, and the median progression-free survival has not yet been reached. When we look at the 12-month estimated PFS, it is 68% in the entire cohort and 72% in patients who had a conforming product. And to put this in context, in the earlier report of CARTITUDE-1, the 1-year estimated PFS was about 77%. So it's tracking in the same range. Longer-term follow-up is needed to see what the median PFS would be. One important thing that I would like to highlight is that sequencing of BCMA-directed therapy is a very important topic in the field right now, with BCMA-directed ADCs in development, BCMA bispecifics that are FDA approved, and BCMA CAR-Ts. So as I mentioned, that 14% of patients had received prior BCMA-directed therapy in our cohort. Most of it was prior ADC, though a substantial proportion did receive prior BCMA bispecific and CAR-T. And not surprisingly, we found that the response rates were lower in patients who had received prior BCMA-directed therapy, and PFS was also lower. Overall response rate was 70%, CR rate was 42%, and median progression-free survival was only 13.6 months. And the type of prior BCMA-directed therapy did not seem to matter. There was no significant differences in the type of prior BCMA therapy in terms of PFS. However, a very important theme emerged, and this is a theme that has been also emerging with other data, is that the timing of last exposure of prior BCMA-directed therapy really matters. So when you separate the patients with 6 months or more, from the last prior BCMA exposure to within 6 months of last prior BCMA exposure at the time of Cilta-Cel, those who had last BCMA exposure within 6 months had inferior outcomes. The overall response rate in those patients was only 54% compared to 94% if the interval was more than 6 months. CR rate was 31% compared to 56%. And the median PFS was 6.2 months compared to 16.8 months. Again, suggesting that if we have to sequence, Cilta-Cel after prior BCMA-directed therapy, if we can, at least allowing an interval of 6 months or greater is important if time allows. And so that is the summary of our findings. We also did some multivariable analysis to understand which patients did better or worse with the CAR-T. And the factors that came out as important, some of them are not surprising, both for PFS and OS. Patients with extramedullary disease, patients with high-risk cytogenetics did worse. Age did not have an impact. But what is interesting is that high baseline ferritin seemed to have an impact for both adverse PFS and overall survival. Prior BCMA-directed therapy was borderline significant with a p-value of 0.08 for inferior PFS. So to summarize the findings of this multi-center study, Cilta-Cel is feasible in a real-world population of patients with myeloma, most of whom would not have met the eligibility criteria. Over half of them would not have met that. It resulted in a high response rate in patients who received standard of care Cilta-Cel that appeared to be durable. And toxicity profile was consistent with clinical trial data, and we are learning the sequencing question after prior BCMA-directed therapy, and an interval of 6 months or more seems to be ideal. Thank you for your attention.